Hello everyone, this is Sadhana Alangar, HL7's Director of Education. Welcome. For this webinar, we have a distinguished set of speakers, each of whom has over 15 years of experience in the healthcare industry. Michelle Thompson is the Vice President of Population Health Management and Plan Operations at Fluid Edge Consulting. Swanand Prabhu Tendolkar is the Senior Vice President of Data Management at CitiusTech. Shobit Saran is the Assistant Vice President of Health Plan and Consulting at CitiusTech. At this time, I'm going to hand over the program to Shobit. Hi, Shobit.
Thank you, Sadhana. Thanks for the introduction. So before I go into the actual content of the webinar, which talks about the new proposed rule, I'll talk about some of the key takeaways which the participants would have from this webinar. So what we thought before we talk about the new proposed rule, we'll cover a quick recap of the rule which was out in March 2020 from CMS, and that's the foundation ruling that is going to be used even for the new proposed rule to incrementally put some updates as well as new requirements that CMS has laid out as part of the proposed ruling. So after we cover the recap, we'll talk about the new proposed rule and its details and policies that are mentioned by CMS. After which we'll cover some of the key use cases, and prior authorization being one of the focus areas. We'll talk about that as one of the important items within this webinar. And towards the end, we'll be covering how the payers should plan to prepare themselves with respect to this new proposed rule. With that, I will move to the next slide. This is a quick agenda slide, kind of talking about what we cover at an overall level. I'll directly dive into the 2020 IPA ruling, which came out as part of March 2020 rule from CMS. And I'll start with Interop Journey to begin with. So as we all know, Interop has been a buzzword in the industry for many years. And this is a quick depiction of how interoperability as an area has traversed its journey through the inception. Talking about FHIR, that is one of the important areas within interoperability. The adoption of FHIR happened in the time frame of 2010-2017, where the provider organizations and EHR systems were the early adopters of FHIR, post which there have been multiple initiatives within the industry in form of Blue Button and Da Vinci that have spun up, where organizations, both payers and providers, have come together to solve for different use cases using FHIR as the standard for data exchange. The focus has been to ensure that patients or members are given control of their own health data and enabling them to manage their care more efficiently. Eventually, with 2020 coming in and CMS as a governing body also launching the new rule that we are all working towards or already have embarked the journey for, the regulatory requirement also enforces the adoption of FHIR, again keeping member and patient at the center to ensure that he or she is given the access to his or her own data. An interesting perspective which I would like to cover on this point is, since the first rule that came in March 2020 talked about data exchange, where member or the healthcare apps have to be the ultimate consumers of data, and the payers are supposed to expose certain set of data sets in form of those apps and members to access it. The new proposed rule, which we'll be talking about as the focus of this webinar, is taking the interoperability journey to the next level, where not only the individual consumers, but also the workflow in form of, say, prior authorization, which is again an important area we'll be talking about. As a workflow optimization area is also something that CMS is kind of enforcing now to be to use FHIR as an interoperability standard. So from individual patient access data to workflow related automation, which eventually helps in improving overall member satisfaction and engagement, is again an healthcare interoperability journey related goal. I'll move to the next slide, talk about how the CMS IPA rule, which came in March 2020 as the foundation rule for payers. So the three main aspects of the rule that came in March 2020 are patient access, provider directory, and peer-to-peer. At the crux of everything, what these rules talk about is to use FHIR as the data exchange mechanism. To be precise, FHIR 4.0.1, or what's called as FHIR R4 as well, is to be used for data exchange. And overall, the intent is to use API-based data for faster access and exchange information in a secured way. Since all of us are working towards implementing this rule anyway, I'll not spend a lot of time on this slide. Rather, I'll focus on talking about the next slide, which brings an interesting perspective on what we as an organization did sometime back in Q4 2020, where we did a survey of large health plans in order to understand how are they looking at FHIR adoption. The outcome of that survey is what you see on this particular screen. While we as an organization continue to work towards the payers and health plans and also provider sponsored health plans to help them be compliant as well as adopt FHIR as a overall standards for data exchange and build a healthcare ecosystem that's FHIR compliant. This particular survey helped us to have an interesting perspective on how do other payers are embarking the journey. So rather than spending time on the actual statistics, what I'll do is I'll request one of my fellow speakers, Swanand, to share his inputs and thoughts on why would some of the numbers indicate the way they are on this slide. I'll pick up one of them. So 89% of the health plan surveyed uh, had a preference of on-prem deployment rather than cloud deployment. And we all know that cloud is the platform that every industry, not only healthcare, is looking for in terms of adoption. However, there's an anomaly in terms of what we found in terms of the survey. So Swanand, what's your perspective on this particular statistics? Any thoughts you would like to share with the group?
Yes, sure. So, in fact, when we did the survey, I remember that we thought that this number is a little bit different than what otherwise we would have expected. But if you look at the first line of the slide, correct, it's mainly about 25 large health plans. It is kind of skewed towards that fraternity. When we talk to mid-size health plans, they're all thinking a lot more about going on cloud. But large health plans, the way when we talk to them again, correct, the way we found out is following. They are already have invested a lot on their on-prem infrastructure and stuff like that. They already have a lot of actual hardware around, and they were thinking that I would initially go on-prem. Let's see how this works, and probably in later years I'll go to cloud. So what they're thinking is they're not thinking to go on cloud for this one particular initiative. They are thinking that they would make cloud migration itself as a enterprise-wide initiative, and it is at that point in time they would be looking at on the cloud deployment for their FHIR resources. So it's not just FHIR that they are looking at. They are looking at moving to cloud as a company, and it would probably take a little while for them, given the size that they have and given the investment that they have made. So that's a insight that we figured out when we kind of got a little bit deeper into this one number.
Yep. Thanks, Anand. That's good to know. Thank you. We'll move on to the next section, which talks about now the actual proposed rule that came in December 2020. So some of the quick callouts from this slide. The rule is applicable for Medicaid, CHIP, and QHP health plans only. It is not applicable for Medicare health plans as per the proposal from CMS. It is as of now effective from January 1st, 2023, but will be subject to be changed once the final ruling comes out from CMS. But that is the current date that the proposal has in terms of the compliance date or the effective date. The other thing I'll call out on this slide, there are rules 1 and 2, which are updates or additions to the existing rule, whereas the next 3, which is rule number 3, 4, 5, are brand new requirements in terms of the proposed rule. So I'll quickly talk one by one. The first rule is for the patient access, that adds additional requirement for prior authorization data to have member or patient have access to his status of prior auth. The second rule talks about peer-to-peer data exchange, where claims and prior authorization data has to be exchanged in addition to the clinical data, which was part of the prior rule of March 2020. Rule number 3 onwards are all new requirements. The first one, number 3, talks about provider access API, which is for exchanging claims, clinical, and prior authorization data. Again, this is for all the data sets that are part of patient access, minus the information that is with respect to cost share and remittance data. Number 4 and number 5 are prior authorization related requirements, which are in form of what's called as DRLS API and PASS API. And both of them are part of prior authorization workflow. And the intent is to have a workflow which is more automated, which reduces the turnaround time. And we'll cover this in detail when Michelle, one of the fellow speakers, will talk about the entire section devoted on each of these rulings. We'll move to the next slide. So before I hand it over to Michelle for the details of each of these rules, I'll cover the benefits of what these rules are going to help any organization achieve. So as we all know, Patient Access API has an overarching goal of making sure member is more informed, he or she is the owner of his or her data, and a better informed member would be able to take care of his own care as well as be more informed about his own data. And the next information around the next rule for peer-to-peer data exchange, just one. Okay. Yeah, for peer-to-peer data exchange talks about claims, clinical, and prior authorization related data exchange, which again is for reducing the burden that that will be there when it comes to exchange of information when a member shifts from one health plan to the other, avoiding any type of repetitive actions that need to be performed, and overall helps in achieving better member satisfaction. Provider Access API would help in having a longitudinal health record for a provider, which eventually would be helpful for a provider to make clinically informed decision. The next two set of APIs for DRLS and PASS are for, again, prior authorization specific workflow. It would help in reducing the prior authorization related time frame that's is spent in the approval or the denial process. So eventually helping in reducing the turnaround that's currently there. Also, whatever are the multiple hops that happen back and forth that happens between payer organization and provider organizations. That will be reduced, which overall will help in improving member satisfaction and a better engagement. So with overall better member engagement and more informed member as the focus of all this rule from CMS point of view, I think without any further ado, I'll hand it over to Michelle to help us go through the details of each and every rule. Over to you, Michelle. You can go to the next section. Thanks.
Thank you, Shobit. So in my sections, over the next several slides, we will talk about the 5 distinct requirements of the proposed rule and doing a little bit more of a deep dive into those requirements. It may be some of the same information that Shobit shared, but in more detail. So going into the first requirement, it mandates that the payers implement and maintain a secure standards-based API that allows the patient or the member, however we may refer to them, to access their own healthcare information. That information, such as prior auth data. So if they've got a prior auth sitting out there for some type of treatment, whether it be a chemo treatment or a series of physical therapy visits, that prior auth data will be out there for them to see. And it can be an active authorization or treatment or any pending authorizations. Now, closed authorizations won't be out there for them to access, but they will be able to see those open active cases and any pending cases. The second piece of data or information they'll be able to access on this API is claims data, and that means any approved or denied claims data, including provider remittances and enrollee cost sharing information. The encounter data from the provider that documents both the clinical diagnosis as well as the services and items that were delivered within that claims. The claim and encounter data must include, so components of that data that must be included on that app or the API will be the enrollee identifiers, the date of service, and the information must be available through the patient to access it on the API no later than 1 business day after the claim is processed by the payer or the data is received by the payer. The plan must provide data back from 2016 in the proposed rule and forward. And also on this, within the data set will be a subset of clinical data. Having access, as Shobit said before, having access to this information will provide a holistic approach to the health information for the patient or member and allow them to make more informed decisions about their health care and also their treatment options. CMS believes that the cost associated with this data exchange will qualify as a quality improvement activity and may be able to be used for purposes of the MLR. So that is a really positive piece of information. The standards the proposed standards that will be used for the APIs are, of course, those per the Office of the National Coordinator for Health Information, ONC as I call them, and follow the Fire Release 4 standards and all the HIPAA security requirements. The implementation guides, these guides are proposed by CMS and are basically a set of profiles with defined attributes that are currently available by HL7 and the other project groups. Those include the Karen Alliance Blue Button Framework, Payer Data Exchange and Documentation Templates and Rules, DTRs, and also the United States Core Data for Interoperability Guide. So additional requirements for this proposed factor are the payers must have a standard third-party onboarding and attestation process in place. This is mandatory. It must be done. Also, the payers must report metrics quarterly on the patient's use of the API. This is going to help CMS really see the impact that the APIs are having. This data, these metrics that must be reported are to be reported to CMS. One consideration here is that payers will need to start building out these components of the report and integrating that data that will need to be included and sent to CMS. So remember, it is a quarterly requirement for the metrics around the access to the API, how the patient or the member is accessing the API. Next slide. So the second of the 5 requirements mandates that the payers implement and maintain another standards-based API that allows sharing of the patient's members' complete health data to a provider for improved care coordination and treatment planning. So the providers will now have access to the same data elements as we talked about before that the member has access to, including that prior auth data, claims and encounter data, and that subset of clinical data. Having experienced this firsthand as a provider and second as the patient, this API is going to be extremely useful in holistic treatment planning and care planning, enhancing that continuum of care that we are all seeking. For example, going into a specialist office or the emergency room, the patient is asked to recite their medical histories and what's happened over the last 5 or 10 years to them. And often there are pieces of information that the patient forgets to tell the provider, or it's not exactly accurate. But with this, that information will be housed within the API for the treating provider to access. So it eliminates a little bit of that quality misalignment for the quality of the data that they receive from the patient. This is really an effort to improve the type and the amount of data that the provider has access to in an attempt to reduce unnecessary care. And I've definitely seen redundancy of care, both having worked on the plan side and the provider side. It'll allow for more coordinated care for patients across the whole healthcare ecosystem. Additional factors for this requirement include providers must maintain a roster of attributed patients to enable the bulk data transfer from the payer. This is in place to improve efficiencies on the payer side. The payer must also set up that one-time opt-in option to avoid multiple complex consents from the members for data sharing. And on the plan side, I know that we could talk about this in forever as getting that consent from the member if you don't have that one-time opt-in. Next slide. The third of the 5 requirements mandates that the payers implement and maintain a standards-based API again for providers to look up prior auth requirements for a particular item or service. This requirement is a game changer for me. Reading this, I'm very excited about it. How many times has an authorization request been sent to the plan only to be sent back to the provider, to be sent back to the plan, to be sent back to the provider for additional documentation requests? It really decreases the efficiency and productivity on both sides of the fence, and it also increases provider abrasion. This is very frustrating to the provider. The proposed rule will allow providers to know in advance what documentation will be needed at each different insurance payer. This is so important to the provider. Again, having been on the provider side, it's extremely taxing to keep up with all the complex requirements of each individual plan for each service. Does it require an authorization? Does it not? It all varies by whatever plan you're accessing. The frustration and confusion factor for the provider is definitely real. And it's definitely real on the plan side for sure. This is an attempt to reduce provider burden and to improve provider to payer information exchange by streamlining the workflow and the access to the coverage requirements. Again, the proposed standard is the same, and the implementation guides around this is the documentation templates and rules, just like the previous. However, there is a new implementation guide added to this section, and that's the coverage decision exchange, the CRD. And there are no additional requirements associated with this factor. Next slide. The fourth of the 5 requirements mandates that the providers have the ability to submit prior authorization requests and receive those responses electronically in FHIR format. What this means to me, and the first thing when I read this rule, was no more faxes. The prior authorizations are definitely necessary, and it's an attempt to make the process work more efficiency. It's an attempt to improve the quality of the health care, timeliness, decrease in administrative cost across the plan and provider. The industry is beginning, I know that we've all seen this in the industry and we're watching the trends, is beginning to trend to more robust and sophisticated auto authorization models, really to improve their staff utilization, their timeliness, their efficiencies. This requirement mandating that the electronic transfer of the prior authorization provides a structure for payers to build out those models of care, which are really important because building out those auto authorization models will decrease the frustration on the provider side. It's simple, it's submitted seamlessly. And on the payer side, it decreases the first review, second review requirements that the authorization goes through the many different roles at the health plan, getting all the way to the clinician who does the exact review. So this prior authorization could really impact efficiencies in staff utilization and staffing models. This requirement mandates that the plan builds the API to support the data exchange and prior authorization. It will allow the 2 systems to communicate and share data electronically, and I'm meaning the 2 systems from the payer side to the provider side. And this will allow the providers to streamline their documentation process through the electronic submission of the prior authorization process by the provider, the electronic response from the plan to the provider, and it's all through the provider's EHR. Of course, this is going to require some modifications on the provider side to the EHR, and also will impact those smaller providers who do not yet have this technology capabilities implemented. The proposed standard is the same, the API, and the implementation guide for this is the prior authorization support, the PAS. The projected outcomes are fewer prior authorization denials and appeals, and improved communication and understanding between the payers, the providers, and the patients. Greater efficiency, as I talked about before, and consistency in those prior authorization decisions. Additional requirements for this factor, Shavit touched on some of these previously. It will reduce the amount of time providers wait to receive a prior authorization. It will also reduce, with that said, it will reduce the amount of time that the plan has to submit that authorization, and it will go for an urgent authorization request down to 72 hours. And for a non-urgent request, it will be 7 calendar days with the proposed rule. The plans must provide a specific reason for any denial, which improves that transparency for the provider and for the patient. And the payers must make public certain metrics that demonstrate how many procedures they are authorizing. So this is pretty important, as I was talking about before, starting to pull those requirements together on the plan side. What is this going to require our plan to build out, and what modifications will we have to make to our processes today that we implement today? Next slide. So the 5th and final requirement is the payer-to-payer API. This requirement mandates payers share any clinical data and share any claims and active or pending prior authorization data from a former member to their new current plan. So the old plan has to share data with the new plan. This requires payers that certain clinical data at the member's request. So it's not a bulk data transfer on every member who moves from one plan to the other, but it has to be at the member's request. It allows the member to take their information with them as they move from payer to payer to create that cumulative health record. So this information is important on the population health management front, really being able to identify, using that information to identify, segment, and appropriately manage those members, spanning the spectrum from, does that member need to be managed in a well program to an emerging risk program, or do we not know what program they are and we need more information? So it's very important that that information come over from the previous payer to the new payer. It's an effort to facilitate informed decision making for the payer, for the member, and also provide efficient care and improved health outcomes. The proposed standard is the same, and the proposed implementation guides are the same as before, using the Care Alliance Blue Button framework, payer data exchange, the documentation templates and rules, the DTR, along with the US CDI guides. Additional requirements for this factor include members must opt in for the data transfer, like I said before, and doing it on enrollment into the new plan. So it'll be a simple process. They check a box. They say, yes, we want the old payer to share my information with my new payer, and that will be the opt-in requirement. If members are enrolled in one or more health plans, the payer must share this data between the health plans no less than quarterly. So again, on the payer side, it's important to start thinking of how are we going to implement these requirements into our current processes, where we are sharing this information quarterly, on a quarterly basis between health plans. With that being said, I am going to turn it over to Swanad now.
Yeah, thanks, Michelle, and let's go to the final section, and it's a potential use cases, and it's not though we have written it as a use cases. It's more going to be a little bit more technical, how things used to be now, and how things would change as we go forward, and that's how we'll have a look at it. So prior of use case, the way it happens right now, and I think Michelle did a good job of talking about that. There are faxes, there are emails, telephone calls at times made, and there are EDI transactions as well. That is 278 is the transaction code that is used for prior auth. There are times when some of the provider payers, they use provider portal, and they tell provider, come to this portal, make a prior auth request from this portal and do the rest. There are certain EMRs which will give screens to connect to payer and then make a prior auth request. And then there are various other things, that is fax and all. We looked at it. Prior auth mixed request is made using any of this method, and then it goes to the payer side, which is their payer data exchange gateway. There are various places where you can find prior auth documents. You can go to payer's website and you can see that. Sometimes payer provides material to the provider, say that, okay, this is what it is for this particular schedule. These are the documents that are required. And then there are a few other web sources, correct, which are like standards, and they say for this schedule, this is the document that is required. But again, one single place which will tell you exactly what is required for the given the request that you are making is something which is in some ways missing. Not that it's not there, but in some ways it is missing. And that actually brings us to challenges. So first is no consistent method to request prior authorization. The second one is there is low adherence to the transaction 278, the XL 278. Whereas we have seen that if you look at transaction 837 and 835, which are about making a claim request and claim response, their adherence is really high. But as far as 270 is concerned, this is a little less. And then there is no single source of order to check for which PA documents that are there. And that actually, all of this thing culminates into longer authorization response at time frame. And these are all the challenges that we see in this particular workflow, the way it is currently happening. Let's look at how this would happen in the future. So this is from left and right. On left hand side is the EHR, that's where the providers are. And I want to make a request for prior auth. And the way I would do it is following. So I would first go and say, are there any PA documentation required for the selected procedure? So I have a patient and who is going to undergo certain procedures. I'll first go and make a request to the payer, stating that this is what it is. So there is a patient called Swanan, and he's probably undergoing some procedure. It will have CPD code, and then the payer will say, yes, there are documents that you need to comply with. That's the first handshake that will happen between providers and payers. The DRLS API, it's basically document requirement lookup. That's the name of the API. There is second DRLS API then that gets fired is okay. Now that you are telling me yes, there are requirements for the documentation. Can you tell us what are the documents that are required for the selected procedures? And again, that request goes to the payer, and payer will then say yes. For the response of second DRLS API, these are the documents that are required. So it will now tell me that I need to have these 3 or 4 things to be supplied for this particular prior auth. And this is the point that Michelle was making, that now it's a complete handshake between the 2 parties, and they know exactly what is to be done. There is no more lookup at some sort of a website, or maybe there is some document that was provided earlier, then I look at it and I'll send out few documents, and then payer will say, no, you have sent me documents which are not sufficient, or you are sending me just too many things also. Out here it is exactly known for this particular request, these are the 3 or 4 or 5, whatever the number of documents it is, those are required. And now payer is ready to actually make a prior auth request. While doing all of these things, on the right hand side we assume it's a payer world, and there will be a FHIR server that payer has, and payer has exposed these to APIs that are FHIR APIs. And if you look at these boxes, those are more like technical ones. So there will be an API management toolkit that payer would be having, to which these APIs are going to be hit. The FHIR server is the one which is put behind the API management, and it will do transformation of what request it gets, and do a lookup inside, and then figure out what is happening. So that's the way we believe payer is going to do the work. At a high level, they are going to require these 3 or 4 kind of these 3 or 4 kind of components which are facing the EHR. Having said that, now let's go to the next slide, which will kind of talk about what happens next. So once this happens, then I will make a actual request. Now here we have PAS API. So PAS API is a prior auth server API. Now I make an authorization request, and what's going to happen is, at this point in time, I'm going to send out all the required documents. So if 3 documents are required, I'll be sending 3 documents. If 4 documents are required, I'll be sending 4 documents. My earlier API calls have actually made my life easy, and it now makes the ball actually lies in the payer's court as well, to say that yes, I had told you that I require these 2 documents, and then hence you have sent me these 3 documents. So we expect less number of trouble at this point in time. The first thing that happens is, with the moment I make a prior auth request, when I say I am saying provider. As a provider, I am making a prior auth request to the payer. First thing payer will do is it will acknowledge it. It will say, yes, I have received your prior auth request. Again, the same parsers and servers and all in the front of it, and on the right hand side, it will have its own prior auth system. So whichever is the prior auth system that they are using, it will now go to the prior auth system that they are currently using, and it will go through the rigor of prior auth. It might take a day or whatever, depending upon the kind of system that they have. And meanwhile, as a provider, I am interested in what has happened with my my request that I had made. So I have another API to call, which will tell me, okay, what happened with my request. So I now use the acknowledgement number and say what happened with my request, and it will keep sending me status stating Well, it is under progress. It is under progress, or we are working on it. Something of that sort. And at some point in time, when payer's prior auth system finishes its job, I'll get the response setting yes, it is it is now authorized or it is not authorized for whatever reason. Correct. Though we expect it's going to be a little less in this case, that it may not be authenticated or it may not be authorized. So we expect that a prior auth could be more. The positive responses could be more because provider knew what documentation to be supported, and that's exactly what provider had supported. So there could be some extreme cases that we feel in which they would the payer would say no, you didn't give me the right document. Because the handshake has already happened. But there still could be some problems maybe with the document itself. Those are the cases where we believe wherein the response could be negative. Otherwise, there will be, in our view, there will be high chances of having the positive response when I make a request for okay, what has happened to my request that I have made. So this is the way we believe pair all these new APIs are going to be there. So there are going to be 4 APIs that that the provider side is going to make. The last is okay. So what do payers need to do? So as part of the rule that has come in last year, all the payers are gearing up to to comply with the rule, and they have developed almost 35 or 40 odd APIs, correct, which are USCDI APIs. What they need to do is they need to add a few more resources for sharing and what is the active and pending prior auth related data. So far they were sharing things like patients data, clinical data, patients claim data. They were also sharing provider directory and things like that. But they were not really sharing data which is related to their workflow. So once when you receive a prior auth request and there is a workflow that takes place in between, and what is happening with that workflow, what is happening with my request, is it processed, is it positive, is it negative? That is something which they were not sharing. So they will have to add a few more file resources which will share this share the status of the workflow which is currently around. The next one is they will require a few new APIs as well. That is to allow request and response of the earlier one. That is what is the requirement of this particular request, and what are the documents that are required, and then I'm going to send back okay, these are documents required. So those are the slightly different kind of APIs which are more of a workflow kind of APIs that they have to now build. They will have to integrate with EHRs in some ways because we believe it will be a little bit odd if in spite of having all this FHIR ecosystem in place, somebody goes and connects to the pairs the sorry uh, the provider portal that payers are giving, and then I see that okay, I as a provider go to provider portal itself and then raise a request using these APIs. So it's going to be a lot more integrated with the EHR. So they will have to probably start thinking about how to integrate with EHRs, or maybe they'll have to collaborate with some of them. That's what we feel. The next one is design metrics and for utilization reporting, because that's what they need to be submitting. So how patient access APIs and prior auth APIs are getting accessed, how many I responded with stating that the status is true or status is false. They have to maintain all these metrics, and they have to see the utilization as well. So is there a way in which I can say, okay, how many prior auth requests that I have received? And we do not think that everything is going to become FHIR API enabled the day this rule comes in picture. Probably there will be an overlap time, and that's where the utilization of these particular things against the earlier one would be required. And the last one is enhanced consent management, because they have to give a more flexibility to the either you call it patient or member, but they have to give more flexibility to them to say that I am opting in for the options, and to give access to the granular levels of the sensitive data. that is something that they will have to do. So these are the things that payers will have to do from a technical front, from the front of getting ready for the new rule or complying with the new rule. So this kind of brings me to the last line or the last slide of the slide that we are looking at. What I would do now is I would actually hand it over to Shobit, because I believe we have received lots of questions, and as initially we thought that we'll have at least 10 minutes or 12 minutes to go over the questions that we received from you folks. So Shobit, can you open up for the question answer now? And if you can read out the questions, you, I, or Michelle, one of us can answer that as well.
Sure, Swanan. Thank you again, Michelle and Swanan. So thanks to everybody, all the participants, for so many questions that we have received. I'll try to bucket some of these questions in certain categories and try to use help of this panel to talk through some of the responses of that. So one overall question that we have, and not going question by question, but at an overall level, there's a question around EDI versus fire-related API that is coming in form of PaaS. So the question is around, can you share a perspective on EDI 278 transaction, which in today's world is used for prior authorization, and how would PaaS service be utilized to replace, or eventually, if it be the case, for processing prior authorization? So Swanan, do you want to respond to that, to this group?
Yeah, I think I kind of talked about this one, but here is what we believe. Okay, so external transactions have been around for quite some time, and there are so many those softwares which are ingrained with that with those external transactions. So what would happen is those will at some point in time those will be taken over by fire. But what we really feel is it's not going to happen in a swoop. So I personally do not think that it would happen that okay, from this day onwards, stop everything else, stop 278 and start fire. There will be a time when both the things will be around. That's what we believe, and then gradually it will change, because there not every provider is probably using an EHR which is going to be making a query to payer and make a fire call. I really do not think that's the way it is currently happening. Almost on let's say a rural area also, it is not really happening. So it's not that this will happen in a swoop, but yes, over a period of time, this is going to change, is what we believe. Yes,
Thanks, Swanan. Thanks, Swanan. By the way, I have also answered few questions on the group as well, so folks would have received some response. So we are trying to also knock off some of the questions as we speak. The next question I'll request Michelle to respond to. So Michelle, the question is, while CMS has proposed these rules for payers to expose data in form of PaaS or DRLS APIs when it comes to prior auth, are there any requirements for provider systems to consume this prior auth request data?
So it's really CMS is approaching this they're taking a stepwise approach to this. So the first phase of the mandate really is around the payer, and the payer will be required to build that API so that the data can be submitted through the EHR into the API. Right now, there's not a requirement for the provider, but the next phase will be that the provider's EHR systems will need to be able to send and consume that prior auth data. The thing about this is that's going to require that the provider make some changes to the way their EHR system functions. And some mainly smaller providers do not have that technical capability built in there yet. And I think I was talking about that earlier, to really facilitate the interoperable exchange of the data. Their EHR systems are not yet prepared to leverage those APIs, wherein the larger providers, the healthcare systems, the hospital systems already have that software, and could use it as soon as it is technically feasible. CMS has predicted that, just a little bit of a stat here, that over the next 10 years, 25% of providers will be successfully using this prior auth API, which equates to about a 2.5% growth rate each year. It's slow but significant. So to answer the question in a simple format, no, not right now. There is not a requirement on the provider at this point.
Thank you, Michelle. There's a question on something which is called as CRD, or there are some comments on CRD, and the question which I see with respect to that is, are there requirements that that cover the eligibility data, which is 270, 271 in X12 world, as part of DRLS API? So I'll share my perspective, and I'll also have Michelle add to it if there is anything on that. So DRLS API, as you saw when Swanan was explaining, there are two calls that are there. The first call is the call that's called the coverage requirement discovery, which is also having the acronym as CRD. That would give the information on what are the details of whether a particular service is covered, what are the if there is a prior authorization requirements against that service or procedure. So those will be part of the DRLS as part of the first call. So simple answer to that is yes, there will be a level of check for what is the coverage from a benefit plan standpoint for a particular service, and that is going to be included as part of DRLS APIs. Michelle, you want to add in terms of any requirements which you have seen or you would like to add on?
No, I think you covered it. Just that they're building off of that one requirement with this particular factor. So I think that you covered and answered the question. I don't have anything to add.
Thank you, Michelle. Moving on, there are some questions which talk about what will be the overall impact to a payer system in terms of any changes that are required, upgrades that are required to be made. So the question is, with respect to these rules, will there be any effect on legacy systems or redevelopment effort that will be required to upgrade to the latest version of systems that a payer organization would have? Swanan, would you like to share your perspective on that?
So all the systems are currently undergoing changes in some ways, because they are all currently responding to the IPA rule that came in last year, and it is due on 1st of July 2021. But yes, if you ask my opinion, then correct, there will be some amount of change that will be required, because and I'll just take an example of the workflow of prior. So probably earlier prior auth workflow, intermediate, what were the status were probably not really available to be sent across to the provider as part of API. But if this needs to be done, then at least that much change is required from the prior auth engine, whichever one the payer is using, correct? So they will have to have something which will hook into the prior auth engine and say, okay, where exactly the status is, and that much information they should be able to suck it out and send it out to the provider. And the second thing is the lookup on the kind of service request. So the first one, where what is the document requirement for the given request? So as I said, as one is undergoing this procedure, what are the requirements? And exactly that schedule has to come up, and the payer should be able to send it out to the providers. So these are the two things. I believe those will be around in any of the prior auth engine, but they need to be made available for the payers to not the payer, but for the APIs to query and send it out as a response to the provider.
Yep. Thanks, Swanand. One point I'll add on top of what Swanand mentioned would be also with respect to assuming that organizations would have already embarked on implementing FHIR-based solution as well as part of the first rule. So whatever finally comes out, of course, as part of the final ruling from CMS, there will be some changes required to the new requirement, to changes required in order to incorporate the new requirements, as well as to update it to something that comes out as an updated requirement, say with respect to patient access API or provider access API, etc. So in addition to the legacy systems, if there is a system which the organizations have stood up in terms of FHIR-based solution, that definitely would also undergo certain amount of upgrades or changes is what we would anticipate. There's another question which, again, Swanand, I'll request your opinion. Rather, there are multiple questions on this point. A broader category of question is, when a provider is sending a prior authorization from an EHR system using PAS APIs, how will they get to know about payer's decision, whether it's an approval or a denial of prior authorization? So what's your perspective on how that information is going to be shared back?
That's about the status flag that will go in the so on the second slide that I showed across, correct? In the PAS one, the first one is acknowledgement, and against acknowledgement, I keep on checking what's the status. So there will be a status flag that will go. So that's the only way I see it happening.
Great. All right, I think we are left with 1 more minute, and there are many more questions, so we'll definitely take up the rest of the questions and make sure those get answered. And with that, I'll hand it over back to Sadhna.
Thank you so much to all of you for your excellent presentation. And also, this seems to be a lot of interest in the topic. Thanks to everyone for attending this webinar, as well as posting your questions. As Shobit said, they will be sending out the answers to the questions later. And so at this time, we're going to end the webinar. Bye, everyone. Have a wonderful rest of the day. Till we meet again. Bye. Bye, Swanand. Bye, Michelle. Bye, Shobit.
Thank you.
Yeah, thanks everybody. Bye.
Thanks to all the organizers. Bye-bye.